Okay. People are starting to come in, so we'll give them just a second while we get settled. And as they come in, I'll introduce myself. I'm Claire Baker. I'm Senior Director of Communications at Beyond Celiac, and I'm filling in, humbly, I'm filling in for Maria Lucci, who's out sick today. So we're a team that backs each other up. So I was happy to jump in and help her out. And thank her for all the work she did to help us get this set up. People are still coming in. I'll start introductions of our guests. Kate Avery, who's Director of Research Engagement, is the other Beyond Celiac person on the town hall today. And she's actually, I'm going to hand the reins over to her soon. She'll be facilitating the conversation and the panel discussion. And with us today are experts, Dan Leffler, MD. He's the Director of Research at the Celiac Center at Beth Israel Deaconess in Boston. He's an Associate Professor of Medicine at Harvard Medical School and the Medical Director at Takeda Pharmaceuticals. Also with us is Doug Jacobstein, also a doctor. He's Vice President of Clinical Development at Prevention Bio, a clinical stage biopharmaceutical company dedicated to intercepting and preventing immune-mediated diseases, including celiac disease. Kate, why don't I turn it over to you?
Sounds good. Thanks, Claire. So Doug and Dan, it's great to have you both here with us to talk about clinical trials in celiac disease, which is a hot topic generally, but especially here at Beyond Celiac. So just to kind of kick things off, it'd be great if both of you could just talk a little bit more about each of your company's specific work in celiac disease. We know that you each have products in the drug development pipeline. So if you could talk about where you're at, what's happening now, what might be coming in the future, that would be great.
Sure, Dan, do you want to start?
Go ahead.
Sure. So as Claire mentioned, I'm Dr. Doug Jacobstein. I'm a pediatric gastroenterologist and Vice President of Clinical Development at Prevention Bio. Prevention Bio is focused on intercepting and preventing autoimmune diseases, and we're in several areas, including type 1 diabetes, lupus, and celiac disease. As Kate mentioned, we currently have a phase 2b study that's going on. The study is in patients with non-responsive celiac disease. And we're looking at a monoclonal antibody, an anti-IL-15 protein, as an adjunct to a gluten-free diet. The study began in August of 2020, and we're currently actively enrolling that trial. And additional information about the trial can be found at our website, which is proactiveceliac.com. There you can find several information about the trial, information about the medication, frequently asked questions about the trial. And then there's an opportunity for patients to learn more and to fill out a brief survey to see if they qualify for the trial and if they're interested in participating.
Great, and hi everyone, great to be here. I'm Dan Leffler. I'm an adult gastroenterologist, so we paired nicely, Doug and I. And I am the global clinical lead for celiac disease at Takeda. Takeda has a long history in GI diseases. We have therapies in inflammatory bowel disease and in irritable bowel syndrome and in acid-related disorders. So we got interested in celiac disease a while back, and we have two potential therapeutics in development right now. One of them is TAK-062, that is an oral enzyme, a third generation glutenase that is designed to break down gluten in the stomach. That is about to start a phase 2b trial. Hopefully that will start this summer. And in patients with ongoing active celiac disease despite a best attempts at a gluten-free diet. The second one is an IV therapy that aims to reset the immune system so that it no longer sees gluten as harmful or foreign. It's a sort of tolerizing agent. It's known as TAK-101. This had a phase 2 study that was published in Gastroenterology earlier last year, showing that it was able to protect against immune activation related to gluten exposure. And that is also going to be starting a follow-on phase 2 study, hopefully this summer. So yes, exciting times across the board in celiac disease.
Great. It's always nice to know that there's so much work being done and so much work being done right now that's happening in celiac disease. So I think most of the celiac disease community probably has an idea of this, but could you talk a little bit about why we need a treatment for celiac disease? So the gluten-free diet is out there. So why would we need a pharmaceutical treatment for celiac disease?
So, I think this can be a really long answer, but I will try to keep it short. I think in my view, celiac disease is a complicated autoimmune disease that affects people's lives in lots of different ways, even, as you all know, well beyond the biology, well beyond what happens in the intestine. And, if you look across basically all of medicine, and especially all of autoimmune diseases, there is no one-size-fits-all treatment for anything out there. And I think we have not really, to pretend like there should be for celiac disease doesn't necessarily respect the heterogeneity of the disease and the diversity of the community. And I think clearly people have different sensitivities to gluten, they have different types of reactions. It has different effects on their lives. And so I think at a basic level, part of, modern personalized medicine is having different options for different people according to their needs and perspectives. And I think that's really, as a foundation, how I would like to see celiac disease developing.
Do you have anything to add?
Yeah, and I would add, I agree with what Dan said, and I would add further that, without any approved therapies for celiac disease besides a gluten-free diet, I think that there are clearly patients out there who would benefit from additional therapies. We know that patients who have celiac disease oftentimes are given the diagnosis, they're referred to a nutritionist, dietitian, told to take the gluten-free diet and everything will get better. And that doesn't happen in a lot of cases. And so I think as Dan mentioned, having options is key, but also recognizing that the gluten-free diet may not fix the damage that's being done, and it also may not alleviate the signs and symptoms that the patients are experiencing of their celiac disease. So having options, I think, is critical.
Yeah, I think that's true. I mean, we talk about that a lot at Beyond Celiac, that the gluten-free diet doesn't work for everyone, and in addition, it's incredibly burdensome. So to have other options, particularly for eating out, for traveling, we think could be really helpful for patients. So like any disease, there's a limit to what we know about celiac disease in general. So maybe we'll start with you, Doug, could you talk about what you think some of the biggest gaps are in our current understanding of celiac disease?
Yeah, sure. And there's a lot there. I mean, obviously, I think at a high level, trying to find a pharmacotherapy that will work in celiac disease is a great unknown, right? We're investigating, several different options. Dan mentioned a few. We're working on one that I think I saw in the announcement for this, that there are currently 14 therapies that are in investigational stages, various investigational stages for celiac currently. So I think that's a big gap in our learning. I think beyond that, understanding a little bit about why patients get the disease. We know that there's a trigger. Obviously, gluten causes the symptoms that patients experience, but we don't know why certain patients or certain people develop celiac disease. And so understanding that at another level, I think, will be important to help finding therapies that may help. If we could find what that trigger is beyond gluten, again, gluten is the trigger, but finding something beyond gluten that's actually causing the immune system to go haywire against gluten would be an important step in the right direction in terms of understanding the disease and filling the gaps that we have.
I think that's a question we hear a lot is, why did I develop celiac disease, as opposed to, my mom, my sister, my brother, who might have the genes but haven't developed the disease. I think that can be a frustration. Right. Dan, do you have anything else to add?
Yeah, no, I completely agree with all that. And I think the other big piece that I would love to see shed some light on is, again, back to the heterogeneity of response. We know that some people, eating the same amount of gluten, some people will have vomiting, others will develop a rash with no GI symptoms. Some people will develop no symptoms at all. And it's really even differentiated from intestinal damage. Some people can have, pretty severe intestinal damage and no symptoms, and other people have mild or no intestinal damage and have a lot of symptoms. And so really understanding what's driving people down different pathways of celiac disease would also be really helpful in helping them understand their disease and helping us, better treat people according to their disease manifestations.
Yeah, that makes sense. I will say, I know we have people on the chat answering questions, but if you guys wanted to throw in a link to the drug development pipeline, then people could see all of the drugs that we know of that are currently in development, but you'll see specifically the ones also that are getting developed by Prevention and Takeda.
There are a couple of questions that I could throw out that might be relevant right now. One is from Sherry. She wonders why trials, why age 70 is the cutoff. And we have an answer in the chat, but it'd be good to hear from the experts. And also a question from Kim. She's 65 now and wonders if there will be a treatment in her lifetime.
So, I think regarding the age cutoff, there's no strict cutoff. Sometimes it's 65, sometimes it's 70, sometimes it's 75. The key is that, when we develop new drugs, we really do so with an abundance of caution, right? And we want to make sure that we are testing them as safely as possible. And we know that people at older ages and also at younger ages can metabolize drugs differently. They can be on different medications, which have impacts. So oftentimes there are just cutoffs just in the beginning until we learn more about the drug. And usually we are able to expand those. So the first trials might be very restrictive in age. And with every trial, as we gain confidence around the safety profile, we can expand those ages outward. And I'd be interested in Doug's opinion on the second question, but I would say, yes, I would very much hope there will be a drug available. I mean, I feel like, we've been saying it's going to be 5 years, and I've been saying that for at least 10 years now. So there's something to that. But I think if the community stays engaged and participates, I think we have a real shot at this in the coming few years.
Yeah, and I would agree. And I think there's a couple things to keep in mind. Obviously, as I mentioned, there are a lot of drugs in the pipeline by a lot of companies. There are a lot of drugs in the pipeline at various stages. So for the first time ever, we have a drug that in celiac disease that's in phase 3, which is a great accomplishment. I would add that, it's important to remember that any therapy that's being developed won't be a one-size-fits-all therapy. So as Dan mentioned, there's a lot of heterogeneity with the disease. And I think that the therapies that are going to come out may work for some, they may not work for others. So I think patience is going to be the key. But I do think that, Kim, in your lifetime, that we will see a therapy or multiple therapies for celiac disease. I remain optimistic in that regard. One other thing, if I can go back to Sherry's question about the age set, I will say one other thing to keep in mind, at least in the last couple of years as it relates to COVID, and I can tell you that this happened with our trial, was while we wanted to have an age limit that was a little bit higher, as Dan mentioned, oftentimes the age can vary by trial. We had initially intended to do the age cutoff for our trial at about 75. And because of COVID and some of the risks that we were seeing in the elderly population as they got older and experienced more signs and symptoms and illness as it relates to COVID, we came down a little bit in order to prevent the risks that were there for patients as they experience COVID. So I think it's important to keep in mind that the age range that's set sometimes has to do not only with the environment that we're in, but also again what comorbidities are out there that you've got to worry about. So something to think about as we move forward. We'd certainly like to increase the age higher than we are right now.
That makes sense. I'm going to jump a little bit off script because I know in our last town hall, this came up a lot. Can you both talk a little bit about other eligibility criteria? So beyond age, we know that, sometimes people have to have a certain set of symptoms. There's there'll be, you know, other diseases that are exclusion criteria, which mean that you couldn't participate in the trial. Can you just talk a little bit about the kind of the theory behind that and why they might be different, why some of those criteria might be different for different trials?
Sure. So, you know, so the criteria, I will say that there are, if you look across trials, there are some similarities and then there are some differences depending on the drug you're looking at. I'll use celiac and in particular GI symptoms in celiac disease, because oftentimes when you look at a celiac trial, and we'll focus on the non-responsive, so NRCD, so non-responsive celiac disease, so patients who continue to have symptoms despite their best effort at a gluten-free diet. Oftentimes, those patients, when we're studying them, we're looking at their GI symptoms, so diarrhea, bloating, chest discomfort, those kinds of things that you'll see that are common to celiac, but are also common to other diseases within the GI tract, other inflammatory conditions within the GI tract, things like Crohn's disease or ulcerative colitis. They oftentimes will overlap. And so when we set eligibility criteria, we oftentimes have to set criteria that allow us to differentiate or see improvements that if you have an overlapping or a condition may not be there. And so that's sometimes what dictates that. Sometimes the way that the drug works will dictate what we can do. If there are some risks, for instance, in the monoclonal antibody category, there's sometimes an increased risk of infection. So we have to make sure that patients don't have infections coming into the study. And sometimes we'll look for underlying infections like tuberculosis. So there are a variety of things that we have to consider when we put together inclusion and exclusion criteria. I know for patients, it's very frustrating, but the goal of the inclusion and exclusion criteria are really set up to try and make a homogeneous population out of a population that may be heterogeneous. And so what I mean by that is to try and take patients that we can draw conclusions on because they're similar, and so that we don't get the wrong conclusions based on things that may allow us not to interpret the data the right way. And so a lot of times what we do with the inclusion exclusion criteria is to try and create a population that's very similar across the range of entrants into the study.
Yeah, and I think the other big class that I would just put in, and I agree with all of that, is, you know, some conditions that require medications that can affect these outcomes. You know, so if somebody has rheumatoid arthritis, right, and you're on an immunomodulatory agent, those can affect the way you react with celiac disease as well, right? And those can make things very complicated. So I think those are the two big categories that I would say, you know, other things that cause GI symptoms and other things that cause you to be on medications that can affect your celiac disease are usually going to be problematic. But as the question asked, you know, there are variations in every trial. So just because you weren't eligible for one trial doesn't necessarily mean you won't be eligible for the next one. So, you know, it can be frustrating, and I totally understand that. But I would, you know, I would keep that enthusiasm, and the next time a trial rolls around, there's no harm in asking if this might be the one that's right for you.
That's helpful. And we, like I said, we hear that a lot. So it's helpful to kind of get an overall picture of why those criteria are in place, and, you know, that they're not just random and designed to keep people out of clinical trials. They're for a purpose. So on the topic of participating in clinical trials, we know that, you know, we need people to participate in order for these trials to happen and to be successful. Could you talk about what you think some of the barriers are to participation in clinical research, especially clinical trials?
Yeah, so I mean, I think there's a number of obvious ones, right? I mean, I think one is that, you know, I think there's just not always a good awareness of the clinical trials and what's out there and what it's like to participate in a clinical trial. I think that a lot of people that first time, if they've never done it, it can be a little overwhelming. There's a lot of information. It can be a little scary. You may be meeting new people, new medical staff you've never met before. There is a sort of a little bit of maybe a courageous aspect to taking that first step. So I think that's a big barrier. And I think, you know, I do think the sites work really hard to be welcoming and informational, and we work really hard to make information very accessible. But I do think that remains a barrier, and it's just something that a lot of people just don't have that degree of familiarity with. I think we're making big strides across, the entire research community in the last couple of years, addressing some of the other barriers of location of trials or, and diversity of trials. And, I think these are places where now with more home visits and more opportunities to really make trials lower burden and more accessible, I'm hoping that some of those barriers that, again, you may have seen, if you participated in a trial or you looked at a trial 5 or 10 years ago, might look very different today. There's just been, I think COVID has pushed a lot of us to do this, but to really have, virtual visits, home visits, disseminated trials in a way that we never really, people talked about, but no one was really doing not too long ago. So I'm hopeful that the barriers will be decreasing over time in a way we haven't seen, before, really.
Doug, do you have anything to add?
Yeah, no, I think Dan touched on several important aspects. One thing that he mentioned what we sometimes get is that the fear of losing your own doctor, and if there's a single site in that's run by a gastroenterologist, isn't your own gastroenterologist in an area. There's a fear that, if I go there, that I'll lose contact with my own physician. And I want to assure people that that's not the case. I think that we get that question a lot. And I also think that, the time commitment aspect of a clinical trial always comes up. And so, as Dan mentioned, there are opportunities for home visits, and I would say, a good trial will lay out the time commitment up front so that there aren't really any surprises. Oftentimes, there's reimbursement for travel. There's reimbursement for time lost. So things like if you miss work or things like that, there may be some remuneration for those lost opportunities at work and things like that. So just make sure that I think that going in, that you ask the right questions about what's offered. If you have concerns about the time commitment, make sure that you understand what the time commitment it is. And oftentimes, again, trials are looking into doing things remotely to allow at least part of the trial to allow patients the flexibility not to have to come to an office, a freestanding office all the time for visits. So, I think those are all concerns that we see. And we really are trying to overcome those barriers to participating. So
it might be helpful to talk a little bit about what the time commitment could look like. So, I know it varies a lot depending on the trial, but maybe Doug, you can talk about, how many visits there are in the prevention trial right now over that span of time. I think it's just helpful to understand the number of visits compared to the amount of time.
Sure. And, I will, let me preface this by saying that every trial is different. And so,
right.
I want to make sure that I'm clear about this, because some people I may mention our trial, some people may say, well, that seems like a lot. Some people may say, well, that doesn't seem too bad, but every trial has its own commitment. So our trial is a 9-month commitment. We do visits about every 2 weeks. In the trial. And that's primarily because the medication that we're using is given every 2 weeks. And so, again, I want to make sure that everyone's clear that the time commitment per visit varies a lot. So the first visit where you meet with a physician and you review, and the study coordinator, and you review the informed consent, and you may have some labs drawn, things like that, that can take a couple hours. The next visit where there's medication given or where you're just checking in with the doctor to see how things are going, that could be a 30-minute visit. So it just depends on the visit type and the visit where you are in the trial. As I mentioned, in our trial, so we do visits about every 2 weeks. We have worked in 4 remote visits into our study over that 9-month period. So we do allow for remote visits. Some trials are asking for, and it's getting pretty common for this to occur, are asking for endoscopy as part of the trial. And so, that can take a little bit longer at certain visits. But there's a wide range of times and commitments that are involved. And so it's really hard to sort of lay that out and really hold your hat to it. Like I said, I think the best way if there's concerns about the number of visits or the time, is to talk to the study coordinator or the investigator or your own physician for that matter about the study and see if it's right for you. Everyone has different, different time schedules and commitments to work and things like that. And so the last thing we want is for patients to join a study because they're interested and then find out that either the time commitment is too much or it wasn't what they had anticipated. Our goal is to provide as much information as we can up front so that there are no surprises as you go through the trial.
Yeah, go ahead.
Sorry, go ahead, Kate. No, I was just going to say that I totally agree with that. And the one other thing that is important to know is that there's always some degree of flexibility, and different visits might be more flexible or less flexible. But it's not like you're going to start and do that 9-month trial, and you have to agree to every specific day, March 15th, and then April 22nd or whatever. You can move things around. Things can shift over the trial. We've even had lots of people say, this month I can't do it, but next month things are going to open up and then I'll be able to start. Or, so there is often, the study staff are always really sort of happy to work with you and work around your schedule to make this, to make it possible if you're otherwise, really interested in doing the study.
Yeah, I think that's important to know, because it can feel like, even when you go to a study website and you see the information about how many visits and what the period of time is, it can still be a little bit daunting to think about how you're going to fit that into your schedule. But knowing that there's flexibility, I think is helpful, because sometimes it does feel like you're signing yourself, like as soon as you say you're eligible, you're signing yourself up to be married to this trial for 9 months, which isn't exactly how it works. So I think that's helpful. And it's also helpful, I think, Dan, you or Doug, one of you mentioned that, a lot of these trials take place in doctors' offices, kind of like your own doctor, even if it's not your own doctor, but a similar kind of space. I know, even as someone who knows what clinical trials look like and knows how that works, in my head, I sometimes picture this like big white sterile laboratory where all of this is taking place, and it's much more, I think, approachable than that. They're mostly regular GIs who are doing this with some regular staff, just like your doctor's office. So I do think that's helpful to remember. So what would happen if a trial can't get enough participants to be completed?
I mean, that's really always sort of the thing we dread the most, right? Because you've put, not just because we've put so much time and effort into it, but also because all the other people who participated, all that effort doesn't necessarily add up to what it was supposed to. And I think what would happen if you really can't get enough patients, which fortunately is uncommon, is that you have to close the trial early and you just don't have confidence in the results. Something might look like it didn't work, but if you had more people, it would be clear it did, or vice versa. Things could look pretty good, but in reality, it wouldn't work if you had the right number of patients in the trial. So I think that's really the danger, is that you don't get the quality, and everyone, patients, physicians, researchers, everyone just didn't get the results they need for all that effort.
Okay, so what we talked, Doug, or you mentioned this a little bit with COVID and how eligibility has expanded and how virtual visits have expanded. But what are some other, if there are other innovative ways that pharmaceutical companies can expand their access to patients and can expand the number of patients who can participate in different ways?
Well, sure. So, I think, it varies a little bit. I will say that besides remote visits, one thing that I've seen and I've heard of in the COVID era is actually kind of a telehealth concept. So you're in a remote area, and I'll just use Arizona, or you're somewhere in a remote area in the desert, and you could actually do an online visit completely. So there would be no, I mentioned home visits. Oftentimes we'll send out someone will come out to your home or your office to meet with you and do the study visit. There are actually, and this is, I think largely, I wasn't familiar with this before COVID. I think it's really it was probably out there, but really it's taken hold more because of COVID, that you could try and do the entire visit remotely. Now, there are some issues with that, obviously. If there's medication issues or there's issues around something that needs to happen at a site, if you have an endoscopy to do or things like that, it may make it more difficult. But that is one innovative thing that I've heard that I think will start to take hold more frequently than before, because again, it will allow us not to have to geographically limit ourselves to where the physicians are to do the trial. So you can have a physician that's located in Texas, and he's doing his daily visits with patients who are all over the U.S. or outside the U.S. for that matter, participating in clinical trials, which I think is a very innovative concept. And we'll start to see that more often, I think.
I think that'll really, I hear a lot from people in like Kansas and Nebraska, who, there's almost never a study site near them who really want to participate, but who, it's far and it's hard to commit to, doing multiple visits over a long time period. So it would be great to see more and more of that happening so that you can capture some of these people who do want to participate, but can't for location reasons. One of the questions that's coming up in the chat is something that hasn't come up yet, which is surprising that we're 30 minutes into a talk about clinical trials, which is a gluten challenge. So it's kind of two parts. Do all studies require some kind of a gluten challenge? And then why would a clinical trial include a gluten challenge?
Yeah, so I'll take a first stab at this. So no, to the first question, not all studies include gluten challenge. And so if that is something that is sort of a non-starter for you, that there's still opportunities out there. And that's, again, one of the things we've mentioned over and over today is that every trial is different, right? And so for some people, it's, the endoscopy might be the thing they don't want to do. For somebody else, it's a gluten. There's all sorts of things. So really each trial is different. And just because one trial may have had one aspect doesn't mean the next one will. So the gluten is, a little bit of a problem child in the research space, I would say. On one level, no one, on the clinical side, we don't like people to eat gluten if we can avoid it, if they can avoid it, right? That's what makes people feel unwell, what can cause damage to the intestine. On the other side, the great benefit we have in celiac disease is that we can test drugs with gluten and really show that they're able to protect against gluten exposure. And if you think about other diseases like, maybe Crohn's disease or I mentioned rheumatoid arthritis, they don't have that ability. So you can get pretty far and do a bunch of trials still being unsure whether you're actually affecting the disease in a real important way. And in celiac disease, we really have the benefit of being able to say, listen, this drug can protect against gluten. That's important to know. Or this drug cannot protect against gluten, and there probably isn't any reason in studying it further. So I think the value of gluten exposure in giving us confidence in the types of therapies we're working on is really, it is a huge advantage, but we know it places a huge burden on patients. So I would say that every trial with gluten is thoughtfully designed to minimize the amount of gluten and to make sure the monitoring of patients in that is really careful so that people, if they get too many symptoms or too sick, they can stop at any time. So there are a lot of safeguards in order, and we really do work hard to minimize the amount of gluten exposure. But I think it's always going to have a place in celiac disease research because it is such a powerful tool.
That makes sense. And even within gluten challenges, we see differences, studies where it's just a 3-day gluten challenge and other studies where it's, 6 weeks of a gluten challenge.
Great point.
And there was a little bit of a related question. What about accidental gluten exposure while you're participating in a clinical trial? Does that goof it up? What happens if real life happens while you're participating in a clinical trial?
Yeah, so that's a good question. No, so the answer to your question, Claire, is no. It won't goof it up. I mean, certainly, for instance, for our trial, again, as I mentioned, we're studying non-responsive celiac disease, and we're doing it as an adjunct to a gluten-free diet. So we want patients who are making their best attempt at a gluten-free diet. We have specific guidelines within our protocol that ask patients not to intentionally cheat. So one of the things about non-responsive celiac disease in general is that patients oftentimes, through no fault of their own, either cross-contamination, they're traveling, are exposed to small amounts of gluten. And quite honestly, that's what we're trying to help with when we're developing therapies for non-responsive celiac disease, is inadvertent exposure. But we would never encourage anyone, certainly in our trial, for non-responsive celiac disease to intentionally ingest gluten. Again, accidents happen, and we understand that, and it won't invalidate the results. It won't, you won't immediately be kicked out. At least in our trial, wouldn't immediately be kicked out. So those things are those measures are put in to accommodate for that. And I would say, oftentimes in celiac trials, we actually see the opposite, which is patients oftentimes who are even on a gluten-free diet, and they feel like they're being watched or they're being studied, and they're participating in a study, will actually change their behaviors even more and really try and avoid all gluten in their diet. And oftentimes that's actually more, I say this, it's great for the patients, don't get me wrong. I encourage that. And that's what we would hope with every gluten-free diet, but it actually makes the trial harder to run, because a lot of the things that were causing symptoms, inadvertent gluten exposure, are now being removed. It's something in general that's called the Hawthorne effect, which is that patients who enter a study behave differently when they're being studied. Now, that's the sort of the dime store psychiatric definition of the Hawthorne effect. As it applies to gluten trials, it's that patients will try and avoid gluten to the extent that they have no exposure at all to gluten. Again, great for the patients, but hard to differentiate between an investigational agent and placebo when they're removing any inadvertent exposure in the study. So.
Yeah, that's come up before in clinical trials to surprise and consternation, frankly. And so,
yeah.
One additional question that is coming in is the patient experience and how it intercepts with their regular healthcare. You talked about it a little bit, but after the study is over, what is a typical situation for what the study participant learns about, were they placebo or were they not? Is there anything to know about their ongoing medical condition that should get conveyed to their healthcare team, that sort of thing?
Sure. So in again, this is going to vary trial to trial a little bit. So, but in general, at the end of a study, oftentimes you'll finish the investigational agent portion. So whether you're randomized to get placebo or you get active substance, that visit you'll have your last visit for that. And then oftentimes there'll be what's called a safety follow-up visit, or there could be several, but at least one safety follow-up visit where you come back and you've been removed from being exposed to drug or placebo. And so you'll do that. Sometimes at that visit, you will have access to your, if there were biopsies that were involved, you'll have access to it. Sometimes you'll have to wait until the end of the study until unblinding occurs. I will say that at least in my experience, once the study is unblinded, we release or the trials that I participated in would release what therapy, or whether you're on placebo or therapy, what you were getting, so that you would know that, and then could get better understanding of whether what the therapy was that you were on. It varies trial to trial. Again, I know that there's an inherent frustration for patients who participate in trials. I think I saw it in the chat. Someone was asking about it. There's an inherent frustration in not being able to find out immediately. But again, because of blinding issues, we can't let one patient know, hey, I was on placebo, or you were on placebo, or you were on drug, and then ruin the blind for everybody else. So we have to be careful about that as we do the study. But ultimately, yeah, we would prefer that all patients are told what group they were randomized to. And Dan, feel free to you know.
Yeah, no, I completely agree. Right. I mean, that is the trick. You know, you can't really unblind the study until the whole study's done. So for the, you know, for a study that can often be a couple of years, you know, that can be a while. But on the other hand, I think there's information that people can get even from the very first visit, right? Because the first thing that happens in any study is a pretty thorough health exam with blood tests, and we'll do HLA typing for celiac disease. And so a lot of that information, every study is different, but a lot of that could be provided right from visit one. And we've had a lot of people just get a lot of benefit because, as we know, follow-up of celiac disease in the community is not so good right now. And so this may be the first time somebody's had, you know, a TTG done in a while. And this is information not from the screening visit that they can get. This is also a chance, you know, because you're getting that thorough exam, that other medical conditions can be found. And I think that's something that happens at every trial, is that, you know, people can be found to have, you know, H. pylori infection or something different that they weren't expecting, but really has a positive impact on their healthcare. And so I think there are benefits and knowledge that you can get even before you've taken your first dose of whatever drug it is.
That's helpful. So along the lines of eligibility, we've talked about age cutoffs at the high end, but we haven't talked about age cutoffs at the low end. So as of right now, there's no pediatric clinical trials in celiac disease. I know the FDA has some specific rules about, you know, when pediatric clinical trials have to be done. Do you think in the next few years we'll start to see pediatric clinical trials in celiac disease happening?
I guess, yes. Sorry, I muted and unmuted. So yes, I think the answer is yes. I think, again, the bar is really making sure that something is safe in adults before you expose children. And so there are some, you know, that's some extra steps. But you also really want to see at least some good hint of efficacy. You don't necessarily need a fully approved drug. That's an often misconception. You can study kids while the drug is still in a, you know, in its phase 2, phase 3 setting before it's been approved and on the market, although that's not done as often as probably I wish it was. I think we all wish that pediatric development is prioritized. It's not for various reasons. But I do think that if, you know, some of the trials that have been put out there on the website are positive in, you know, the studies that are ongoing, a lot of these phase 2 studies, there's no reason that either as part of the phase 2 studies or is alongside phase 3 studies, adolescents at least couldn't be included. So I think, you know, I think there's a clear, and Doug, I'd be interested in your opinion as a pediatric gastroenterologist, but I think there's a clear case to be made that there's a big unmet need in teenagers for sure, and kids going off to college where gluten exposure just happens, right? Younger kids, I think it's a little bit more of a challenging risk-benefit ratio, but I personally would love to see clinical trials in teenagers start in the near future. And that's, you know, I can tell you that for our upcoming trial of TACO-6.2, the gluten enzyme, that if we get good efficacy in the first part of our study in adults, we do plan on including adolescents age 12 and up in the second part of our trial. So I think celiac disease, it's been such a pediatric forward condition, I guess, in one way of saying it. It would be a shame if that didn't translate out to therapeutics.
Yeah, and you know, I would agree, Dan. And you know, I think that there are some very interesting opportunities that are rising in not within celiac, but I think that will carry over to the celiac space as more drugs get developed, which is to start including adolescents, you know, 13, 14, 15, 16-year-olds into phase 2B or certainly phase 3 trials, which will allow older children. And I think, you know, in older children and adolescents, those are oftentimes the hardest ones to control on gluten-free diets because they're off, you know, away from home and doing things on their own. That having that opportunity to get them into clinical trials sooner would be a great opportunity. And I think that it will lend itself well in phase 3 trials, certainly moving forward. So
I'll put a plug in for our research summit in April. We did have a whole discussion on pediatric clinical trials. We heard from Alessio Fasano and from Shana Coburn. who both talked about it from a kind of a doctor perspective. And then we also heard from a mom and her son who talked about clinical trials from their perspective as well. But I thought was really interesting and helpful to hear from patients directly about what they want. The son was up for anything. So we'll sign him up for the TACO 6-2 trial, Dan.
I think he might have been picturing cupcakes and not a slurry.
So someone asked in the chat, and I thought this was an interesting thing, can you participate in multiple phases of the same trial? So if you participate in the phase 1 trial of a drug, could you still then participate? I guess, could you like keep following that that same drug and participate in phases 2 and 3?
Yeah, so there's nothing, again, this is going to be very company dependent, trial dependent, but there would be nothing specifically that I've seen that would eliminate that. The only thing I would say is that in general, there are oftentimes rules for washout periods, meaning that depending on the half-life, how long it takes the body to clear the drug, there may be a time lag for when you can participate in another study. And that's true. The corollary to the question that was asked, not just about one drug, but can you participate in multiple studies across companies? And the general answer is yes, provided that, again, that you've had the proper washout period for whatever investigational agent you were on before. And then that'll allow you to participate in that in another study. So I think it would be true either internally within the series of trials within a single company or across companies, or across drug classes, or whatever the case may be. So
that's helpful. Yes, I've met people who in a different job recruiting participants for studies, but who that was how they'd made a career, was participating in clinical trials and clinical studies, which is very interesting. Apparently you can spend a lot of time in a lab and they'll pay you to be there for months for different kinds of studies. No celiac disease studies are sending you away for months, so don't worry about that. So Heidi asked a question, why do most trials require celiac disease to be biopsy confirmed? So not just confirmed by a blood test, but someone has to have also had a biopsy, which I think is a question that we hear a lot. And I don't think there's a clinical trial right now that's not requiring a biopsy diagnosis.
Yeah, that's true right now. That may change in the future. I think there's a couple reasons, right? One is, we really want to make as absolutely sure as possible that the people in the trial actually have celiac disease. Because obviously if people get in the trial who don't have celiac disease, it really skews the results. And honestly, this is every trial we find people who don't have celiac disease. And usually we catch that by HLA typing, but it's not an insignificant number. You'd be surprised of how many people we have to have that. I remember, back when I was just a site investigator at Beth Israel, we'd have to have that awkward conversation of like, okay, yes, you've been on a gluten-free diet and you think you have celiac disease, but honestly, that it just is not looking like you really do have celiac disease because you're not carrying the right genes. So that it's just part of that, making sure that in these carefully monitored clinical trials, where every patient really counts, that we are having the best chances of people actually having celiac disease. There's some regulatory considerations as well, but we do know that more and more people, especially in the COVID era, have been diagnosed by serology only. And that likely, with stringent criteria, can be very, very accurate. So I do think there may be time in the future where if you have at least good documentation of meeting high quality serologic diagnostic criteria, you could get in without a biopsy, but we're not quite there yet for most trials, at least.
That makes sense. One of the questions that came in before when people signed up is about monitoring tests. So that kind of ties in here. Is there ongoing research about better monitoring tests for celiac disease? Dan, you talked about how one of the things we don't understand is why some people could have damage and not symptoms, or symptoms but not damage. And without a biopsy, which is obviously invasive, you don't really know the state of your small intestine.
Yeah, I mean, I think, yes, I think that we're going to be sort of stuck with biopsy for the foreseeable future for a lot of different reasons. It is a gold standard. But I think everyone recognizes that, endoscopies aren't super fun. They're invasive and they're also imperfect, right? You're only looking at a small amount of the intestine. And there has been a lot of really interesting research into other ways of monitoring celiac disease. In the end, we're always going to want to know that the intestine is better or worse or whatever, depending on the type of trial. So I think we are going to be doing biopsies, but whether there's other ways of looking at the intestine with pill cameras or other new blood tests to sort of see how active the immune system is. We really have, especially on the immune front, we have ways of looking at gluten specific white blood cells in ways now that we never had before. So I do think there's a lot of really fascinating technology that's coming to the forefront. And a lot of it honestly gets tested in these clinical trials. Even if the goal of the clinical trial is really predominantly look at the drug, the whole scientific community gets a lot because a lot of these biomarkers, a lot of these new monitoring technologies get their real sort of road test in these trials. So I think maybe that's answering a different question is that there can be a huge amount of benefit to the scientific and to the celiac community, even if the trial sort of in quotes fails because the drug doesn't work. And no one should ever look at that, their efforts were wasted because the drug wasn't successful, because that's really not the way it works.
That's good to know. That just so that you can kind of cram so much scientific research into one specific trial. I had one other question from the questions that were submitted. What research is happening in diversity in celiac disease? So I know that, there's a lot of discussion about this in the celiac disease community. A lot of the clinical trials to date have been very undiverse. Is there a specific push that either one of you sees out there to try to enroll more diverse participants in clinical trials, or try to have a better understanding of, who develops celiac disease?
Yeah, I think just in general, it used to be thought that it was a Northern European disease alone, and I think that we're obviously seeing that that celiac is everywhere. It's in India, it's in Asia, and so I think that as a group, and I'll just say I'll take this back to our own clinical trial. We have no limits or restrictions on any sort of group, whatever, anything that would restrict the ability to come into our trial. So we would encourage it. I think there's there's kind of two different questions, which is, do you restrict it? Well, the answer is no, but then how do you improve on it? And I think, things like this, measures that are taking place to try and get more clinicians and in more diverse areas to participate in clinical trials, and encourage the patients that they see on a regular basis to participate in clinical trials, I think is crucial to increasing the diversity that we see with any trial. We're happy to entertain, like I said, any site that's interested in participating. And again, we welcome anyone who's interested in participating in our trial to participate. So there should be no barriers as far as I'm concerned. As an industry, I think we can all do better at recruiting a diverse population for clinical trials. It should not be an entirely single group of patients that are participating. So I welcome it. Again, any suggestions, any help that the Beyond Celiac can provide to encourage a more diverse population to join trials at any point. So.
Yeah, and I think I completely agree. And I would just add that the problem actually starts well before trial participation, because we know that physicians just aren't diagnosing people of diversity. They still, a lot of physicians just won't test anyone who doesn't look like that classic, Irish Italian descent for celiac disease. And we see that all the time, where there's good literature saying that if you're not of the, European demographic, it takes a lot longer to get diagnosed, if ever you get diagnosed. So I think, a lot of the work actually that Beyond Celiac is really starting now with diversity, I think will lend itself downstream to better diversity in clinical trials if we can get more diversity in the actual celiac population than we've seen to date.
Yes, that question was not intended to be a setup for me to plug our own research, but I will. We do have an abstract that's getting presented at Digestive Disease Week, which is the big gastrointestinal conference that happens every year. And it's all about research that we're doing with the National Minority Quality Forum. And we looked at diagnoses of celiac disease in people on Medicare and Medicaid, and then potential undiagnosed or misdiagnosed celiac disease as well. So that's getting presented on Tuesday, and we'll have more information on our website once the presentation happens, because we can't talk about it until then, specifically until then. But there is information on our website about that project in general. And we also had a discussion about diversity at our recent research summit. And I think we got at your point, Dan, that it starts really early. It starts with, you know, who is a physician, and, you know, what are the barriers to becoming a doctor. So it will take a long time to solve that problem completely, unfortunately. So I think, Claire, were you going to? I
was going to jump in. Yeah. We're getting close to the end of our time here. There's an interesting question. I think it's interesting that came in the chat about clinical trials investigating neurological symptoms rather than GI symptoms. So is there anything in the works there?
Yeah, so I will say that in terms of pharmacotherapies, I'm not aware of a specific trial looking that. Dan, you may know better than I do, but I'm not aware of that. Kate, I don't know if you want to again plug one of the research awards that was given at the summit. Was actually a British group and a PhD, I believe, that was looking at MRIs of patients with neurologic findings from celiac disease. And I thought it was a very interesting presentation. And again, you feel free, Kate, to plug that talk, but also to say that there is research going on. It may not be pharmacotherapy, but there definitely is looking at neurologic symptoms associated with celiac disease.
It's almost like we practice these setups. It's great. Yes, Ian Kroll from the University of Sheffield, we gave him and Dr. Nigel Hoggard a grant in the last July, and they are studying the neurological symptoms and implications of celiac disease. Their lab has done a lot of really interesting research into what's happening in the brains of people in celiac disease, particularly people who aren't following a gluten-free diet, in addition to people who are. So there's definitely a video from our summit, and we've done some other write-ups of what they've done. But yes, they've done some really interesting research that we've been trying to plug as much as we can, because we just think it's so important to talk about not just GI symptoms, but all the different symptoms of celiac disease. So is there any other last questions, Claire, or are we calling that the last one?
I think we should wrap up. Any closing comments from our panelists?
No, thank you again for hosting. This has been a great discussion. A lot of wonderful questions as always. So thanks again.
Yeah, I appreciate the time and everyone's joining in on the call and the great questions that came in both ahead of the call and during the call. Certainly, if there are additional questions afterwards, feel free to reach out. I think through Beyond Celiac, again, Kate, I don't want to volunteer you and Claire, but certainly if there are questions that come up, reach out if it's your local doctor. Happy to entertain any questions that come up. So thanks again.
Very good.
Thank you both.
Go ahead, Kate.
Thank you both for being here and for sharing your time and all of your knowledge about celiac disease and clinical trials. I think we hope that there are many more successful clinical trials in the future, and we'll continue to do our part to make that happen.
If you want to learn more about where you can find clinical trials, sign up for clinical trials, and see the ones that Beyond Celiac is helping recruit for, you can go to beyondceliac.org/clinical trials. And also, happy Celiac Awareness Month. We are all month long raising money to drive research for treatments and a cure. And the easiest, best way to do that is to join our Step Beyond Celiac virtual 5K from wherever you are. You can find out more information by going to stepbeyondceliac.org, and you'll get information about how you can participate and get a fundraising team and be part of the solution for research and a cure. So thanks, everyone. We're going to call it a day. We will post this replay as soon as it's ready, and we'll let you know when the next town hall is coming up. Thanks, everybody.
Thank you.
Thank you.
Thanks.
Bye-bye.